Hi, this is Amr Abdelgawad from Texas Tech El Paso. We're going to give a lecture about pediatric fractures for pediatrician. This is the first lecture in this series. What are the objectives of this series of lecture? The first thing is to discuss the general aspects of pediatric fracture, and in this lecture we're going to concentrate on this objective. The rest of the objectives of this series is what is the management of common pediatric fractures that you see them in your office or in the ER, and how can you differentiate between the fracture that needs urgent referral and those who can be referred to the office, and finally what are the most commonly missed conditions in the ER. What are the types of fracture in children? First type is the complete fracture. This is an X-ray of the proximal humerus of a skeletally immature child. You can know it's a skeletally immature because you can see the growth plate here of the proximal humerus and the growth plate of the acromion. Uh, this is a complete fracture. It means that the fracture end had displaced in relation to each other. So if you see this is one fracture end, this is another fracture end, they are not in contact with each other. Second type of fracture in children is the green stick fracture. Green stick fractures mean angulation without displacement. So this is an anteroposterior view of the both bone forearm in a child. You can see a fracture of the radius and the ulna. If you see the lateral view, you can see obvious angulation here, about 25 to 30 degree. There is no displacement of the fracture end. So if you see this fracture in comparison to this, the fracture end are still aligned, however, they are angulated. So there is angulation but no displacement. Torus fracture is a very common fracture in kids. Torus fracture, or sometimes referred to as buccal fracture, in which one cortex only failed. So if you see this picture of an anteroposterior view of the distal radius and ulna, there is a very small irregularity here. However, if you see the lateral view, there is on the dorsal aspect there is a step here. On the volar aspect there is no step, so that means that the dorsal aspect had failed in this case. So this is a torus fracture. Torus fracture means that there is only one cortex had failed. This fracture does not have angulation or displacement. These are very stable fracture. They can be managed by the pediatrician and they don't have to be transferred to the orthopedic surgeon. Another characteristic type of fractures in children is what we call plastic deformation. It happens only in children because the bones in children are malleable. So let's see this X-ray of both bone forearm in a child. The radius has a complete fracture. If you see the fracture are displaced and angulated. On the ulna, you can see an obvious fracture. However, the bone is bent throughout its length. And you can see also in this view, the bone is bent throughout its length. This is called plastic deformation. It means that the bone throughout its whole length is bent, but there is no one specific area in which it is broken in. Now we're going to discuss a very important type of fracture that happen in children. It's called Salter-Harris injuries. Salter-Harris injuries means that the fracture had went through the growth plate. We all know that the growth plate is or what called the physis, is the area in which we grow. It is responsible for the longitudinal growth of the bone. And this is obviously a weak point in the children's skeleton. And according to the direction of the injury and how the injury will travel, we will have different types of Salter-Harris injury. Salter-Harris injury type 1, in this case, the injury went through the growth plate as a whole with separation of the epiphysis from the metaphysis. Salter-Harris type 2, the injury had gone through the growth plate. However, in the last part of that, it went through the metaphysis. This results in epiphysis with part of the metaphysis on one side and the shaft with the rest of the metaphysis on the other side. Salter-Harris type 3 is the injury went through the epiphysis and then went through the growth plate. This results in the metaphysis with part of the epiphysis on one side and the rest of the epiphysis on the other side. Salter-Harris type 4 is similar to Salter-Harris type 3, however, with part of the epiphysis there will be a small part of the metaphysis. So again, this is normal picture of a growth plate. This is type 1, in which the whole epiphysis had moved in relation to the metaphysis. Type 2 is the whole epiphysis with part of the metaphysis. Type 3, only part of the epiphysis. Type 4, part of the epiphysis with part of the metaphysis. Type 5 is a specific type of Salter-Harris type injury. It's usually diagnosed as a retrospective diagnosis because there is no displacement of the fracture. It's just narrowing of the growth plate, which is very difficult to detect. How can we diagnose type 5? It's usually diagnosed retrospective when we have any growth disturbance, as we are going to describe later on. I need just to say that type 2 is the most common type of Salter-Harris injuries. So let's discuss why is the Salter-Harris injuries different from other injuries. What is the possible complication that may result from Salter-Harris injury? We discussed that growth happens as a result of cell division of the physis and the growth plate. So if there is an injury to this growth plate, there will not be no longer longitudinal growth of the bone. If this growth disturbance happened uniformly through the growth plate, that will result in a short bone. If it happens in part of the growth plate with the remaining still growing, it will result in a deformity of the bone. We're going to discuss that later in more details. So let's see this x-ray. This is an x-ray of an ankle of a 12-year-old boy with a twisting injury. If you see here, the fracture goes in the metaphysis and then continues there into the growth plate or the physis. This result on the shaft with the shaft on one side and the epiphysis with part of the metaphysis on the other side. This is after close reduction. So this type of injury, if you go here and see which type of these will fall into, you'll find it's type 2, because the whole epiphysis with part of the metaphysis on one side, the shaft on the other side. So this is type 2. Again, this is the most common type of Salter-Harris injuries. This is another x-ray of the ankle of a 14-year-old with a twisting injury. If you see, there is a fracture that went through the epiphysis and the growth plate. This is the picture after open reduction and internal fixation with a screw. So this result in the shaft and the epiphysis on one side and part of the epiphysis on the other side. If you go back to this graph, you'll find this is represent type 3 injury. Now we're going to discuss what is the general management of the fracture. How can you manage a fracture that you see in your office or in the ER? History. You have to take a detailed history from the parents or the caregiver. You have to assess if the mechanism of injury given by the family is consistent with the injury that you see or not, keeping in mind that some injuries that happen to the children are due to child abuse or non-accidental trauma. After that, you have to examine the child. Most, if not all, fractures will present in the affected extremity with three things: pain, swelling, and deformity. Pain, swelling, and deformity is the major elements on the exam of any fracture. Neurovascular exam is very important in case of a fracture. I would say this is one of the most important take-home message that you need to get from this lecture. Whenever you see a fracture, you have to assess the vascularity distal to the fractures and the nerves distal to the fractures. So for example, if there is a fracture in the elbow or in the forearm, you need to make sure that there is a good distal pulses similar to the other extremity, and that the neural exam of the hand is intact. I'm going to show you a video now for examination of the posterior interosseous nerve for a child who had an elbow fracture.
Give me thumb up.
You see that the child is not able to extend his thumb. This is an indication that he had a posterior interosseous nerve injury. After doing the exam and the history and the exam, you go now to the imaging step. Most of the fractures can be detected with the x-rays alone. Remember, in the x-rays, there is two important things that you have to keep in mind. First is in the x-rays has to show the joint above and below the area that the child is complaining of. The second thing is you have to get two perpendicular views, because one view may fool you a lot. You may think it's a non-displaced fracture or there is no fracture at all. However, when you get the perpendicular view, you will see the fracture more obvious and you can see the displacement. Other modalities for imaging like CT, MRI, and bone scan are rarely needed. Now we're going to speak about the general treatment of fractures. How can you treat a fracture that you saw in the ER or in your office? First thing is pain control. Pain control is usually achieved through narcotics or acetaminophen. Please keep in mind that some orthopedic surgeons don't like using non-steroidal anti-inflammatory medications for children with fracture because of its theoretical effect on fracture healing. The second step is splinting of a fracture. And remember, you have to do a neurovascular assessment before and after splinting. In a separate video, I'm going to show you how to do splint of the upper and the lower extremity. After that comes the step of orthopedic referral. There's three scenarios. If the fracture is displaced or angulated, I would get an urgent orthopedic consult or refer the patient to an orthopedic surgeon who can accept him right away in his office. If the fracture is non-displaced, you can apply the splint for comfort and then send him for regular orthopedic referral within 1 or 2 days. The last scenario, if it's a buccal fracture, this can be wholly managed from start to end by pediatrician without need for referral. Now we're going to speak about open fractures. What is the definition of open fracture? Open fractures mean a fracture that has a communication between the fracture hematoma and the external environment. The external environment in the vast majority of cases is the skin. So if you see a fracture with a nearby skin laceration, that's an open fracture. Open fracture are classified into 1, 2, and 3. Open fracture type 1 is a small puncture wound, as you can see here. We usually describe this as happened from within. It means that the fracture end went through the muscle and caused the puncture of the skin wound. This is usually less than 1 centimeter. Type 2 open fracture is more involved. The skin laceration is from 1 to 10 centimeter. There is more involvement of the soft tissue with more contamination. Type 3 is further classified to A, B, and 3. Type 3A is an open fracture in which the bone ends can be seen through the laceration, as you can see in this example. Distal humeral fracture with the distal humerus can be seen from the fracture and from the skin laceration. Type 3B is more involvement of the soft tissue, in which you cannot close the soft tissue primarily, and you have to do either skin graft or plastic flap coverage, or apply a wound vac for a while. Type 3C, in which it's an open fracture with affection of nerves or vessels. What is the general treatment of open fracture? The most important thing in open fracture is you have to give antibiotic as soon as possible. Remember, the open fractures are contaminated fractures, so you have to give the antibiotic as soon as possible, because it was found that the earlier you give the antibiotic, the less incidence of infection that this children is going to get. What is the type of the antibiotic that you're going to give? It depends on what is the type of the open fracture. Type 1 and type 2, usually you give first generation cephalosporin, and if there is an allergy, you can give clindamycin. Type 3 fractures, you add aminoglycosides, gentamicin, to the first generation cephalosporin. And remember, if the fracture happened with gross contamination or farm injuries or deep wounds, and you're worried about anaerobes, you add penicillin. So again, 1 and 2, first generation cephalosporin, you can give clindamycin in case of allergy. Type 3, you add aminoglycosides to the cephalosporins, and if you are worried about anaerobes like farm injuries, gross contaminations, and deep wounds, you add penicillin. Usually the antibiotic is given for about 48 hours, and it is repeated with any procedure. So if this child goes to the OR for debridement or for flap coverage, you repeat the antibiotic for another 48 hours. Remember, open fractures are emergencies, so you have to get an urgent orthopedic consult for debridement and evaluation. Let's speak now about the complications of a fracture in general. So this is the general complications of fractures. Neurovascular injury, this is extremely important, as I had mentioned before. If injuries and the fracture end can cause injury to the vessels or the nerves distal to the fracture. Growth disturbance. So this is a 13-year-old girl that 1 year ago had an injury to her knee, and then she presented a few months after that with deformity of her right knee. So if you compare her right knee to the left knee, you see that she is hyperextending, or what we call recurvatum deformity in this knee. This is the x-ray of the right knee, this is the x-ray of the left knee. If you see here, the anterior part of the right knee is the growth plate is fused. It means that it is not existing. This is in comparison here to the left side, which is still growing. So this child had actually a type 5 Salter-Harris injury of the anterior part of her growth plate of the proximal tibia. So the anterior part was not growing, the posterior part was growing, and this caused the change of the shape of the proximal tibia. Compare the shape of the proximal tibia here to the proximal tibia on the left side, and you will see the difference. So this is a growth disturbance due to a Salter-Harris type 5, which partially affected the anterior part of the proximal tibia. Malunion is another complication that can happen to the fracture. This child 2 years ago had an elbow fracture, and he's presenting now with a malunited fracture. We call it cubitus varus deformity. It means his elbow is pointing inward. Non-union is another complication that can happen in pediatric fractures. Of course, it's not as common as adults, but still can happen. One of the common fractures that can end with non-union is the lateral condyle fracture. This is a picture, X-ray picture for a child presenting few years after lateral condyle fractures. You can see here the lateral condyle with the capitellum with complete resorption of this part of the distal humerus, indicating that this is a non-union process. Limb length discrepancy, that happens when there is an injury to the growth plate. This girl had a fractured femur a few years ago that resulted in injury to her growth plate on her left side. If you can see, her left side is 5 centimeters shorter than the right side. We did lengthening of this child by application of external fixator. Compartment syndrome is very important. We are going to discuss this in details. Let's speak now about another phenomena that happens with fractures of the children, which is called remodeling. Remodeling means that if there is displacement or angulation of the fracture with continued growth of the child, this fracture will realign itself. If you can see this X-ray, this is a distal radius and ulna fracture that was managed with closed reduction and percutaneous K-wires of the radius. The ulna was not operated upon, and a few months later you can see the difference between the X-ray of the ulna and the healing and remodeling that happened later on. Here you can see the displacement of the fracture, and here you can see how smooth the ulna is getting by the remodeling process. Now we're going to speak about compartment syndrome. Compartment syndrome is a very important topic. What is compartment syndrome? Compartment syndrome is elevation of the interstitial pressure in a closed osteofascial compartment that result in microvascular compromise. It means that the pressure inside a closed osteofascial compartment is going to increase, and then it's going to affect the structures inside the compartment, whether it is nerves or muscles. How can you diagnose compartment syndrome? Remember, compartment syndrome is a mainly clinical diagnosis. Tense non-compressible swelling. This is very important. So if you have a child with injury to the extremity and then he started to develop tense swelling, non-compressible, that's an indication of development of compartment syndrome. One of the very early signs that can help you with diagnosis of compartment syndrome is increase in the narcotic requirement. So if you have a child that was doing okay and all of a sudden he started asking for more narcotics, that should raise your suspicion of this child may be going into compartment syndrome. When you examine the child, one of the things that can you depend is severe excruciating pain with passive stretch of the distal joint. So if you're suspecting compartment syndrome of the forearm, and then you come to the fingers and dorsiflex them, you will find the child complaining of severe excruciating pain. The same will happen if you dorsiflex the toes in case of suspecting compartment syndrome of the leg. I have to warn you, don't wait for paresthesia, pulselessness, and paralysis. These are very late finding, and sometimes the compartment syndrome can develop without even having a pulselessness limp. So the presence of good pulses does not exclude the diagnosis of compartment syndrome. This is extremely important. Don't wait till the child is pulseless. It may never happen. And remember that compartment syndrome is more common with fractures of the leg and the forearm. As we said, compartment syndrome is a clinical diagnosis. However, you still can measure the compartment pressure if you want. We don't do this in every case. The indication to measure the pressure within the compartment if you're not sure of your diagnosis, or if the child is not very responsive to tell you if he has pain or not. For example, children with head trauma or children who are under heavy dose of narcotics. In this case, you would like to measure the compartment pressure. You use a specific device with a needle that you introduce into the compartment. If the compartment pressure is more than 30, or the difference between the diastolic and the compartment is less than 30, this may be an indication that this child has a compartment syndrome. So for example, if the compartment pressure is 35, that's an indication that this child has a compartment syndrome. Or if the compartment pressure is 28 and this child is shocked, his diastolic is only, for example, 50, so the difference between the 50 and 28 is 22, so this is less than 30, so this is also an indication of compartment syndrome. So what is the management of compartment syndrome? Once the compartment syndrome is suspected, you have to start moving quickly. So first thing, the cast and splint should be removed or split immediately, and it has to be split completely. And then the extremity should be elevated to the level of the heart. If you raise it above the level of the heart, remember you're going to decrease your infusion pressure, and if you put it below the level of the heart, that may cause more swelling. So the best thing is to handle the extremity at the level of the heart. And then the most important thing when you suspect compartment syndrome is you have to do an urgent orthopedic consult, and it has to be urgent. Because remember that if there is a delay in the management of more than 8 hours, irreparable damage to the muscles and nerves can happen. What is the orthopedic surgeon going to do? They are going to do fasciotomy. It means they're going to release the fascia of the compartment, allowing the soft tissue to expand. By this, we have finished the general aspects of the fracture, general examination, management, and complications of fracture. Let's take this question as an example. This question was from the prep in 2009. It described a scenario of a 12-year-old child. He had a twisting injury. This is his x-rays, and then they are asking you a general question. What is the most likely complication of this injury? Let's now describe the x-rays. The x-rays, you see here the fracture through the growth plate. You can see here, obviously, here is the fracture went in the metaphysis, went through the growth plate here, and you can see it also in this area. So as we discussed before in the Salter-Hess injuries, what is the possible complication that can happen with Salter-Hess injury? It is growth arrest, correct. So you had this correct, it's a tibial growth arrest. Thank you very much for your listening. I hope you will continue listening to the rest of the lectures in this series. Thanks.